the oral cavity, the infection of the oral cavity. So now we go down of the GIT, so go to esophagus. No? And today's lecture is esophagus, infections of the esophagus and stomach and duodenum. All right, so about GI infections. Okay, so regarding esophagus, the infections of the esophagus, the inflammation of the esophagus is known as esophagitis, right? So esophagitis, there are many causes of esophagitis. Now the today lecture is focused only the esophagitis caused by microorganism. That is infectious esophagitis. Actually, the infectious, microbial causes of esophagitis is not very common. So other causes like reflux esophagitis, something like alcohol. Alcohol can cause esophagitis, drug-induced esophagitis that are more common than the infectious esophagitis. I think these topics will be covered by pathology. So for microbiology aspect, only microbial causes of esophagitis. So you know that esophagitis is the rare cause. Infectious esophagitis is rare cause. So there are very few bacteria can cause esophagitis. So most of the esophagitis is caused by fungi, the fungus. So even though the fungus are out of many fungi, the common cause of the infectious esophagitis is Candida, the yeast, Candida albicans. So actually the Candida albicans is the normal flora. They have not very virulent, they are normal flora. But if the patient is associated with immunocompromised condition like HIV/AIDS, AIDS, or some other causes of immune deficiency, so this Candida albicans can cause esophagitis. The normal condition, normal immune system, normally immunocompetent people, the Candida albicans is the normal flora. They cannot cause, but association with immunocompromised, the Candida can cause Candida esophagitis. So apart from this Candida, some viruses like herpes, herpetic esophagitis. So herpes like herpes simplex, cytomegalovirus, varicella zoster virus. You already know that these are herpes group. So these herpes virus also can cause the esophagitis, especially CMV. So this CMV, Candida, these organisms are associated with HIV, HIV/AIDS, immunocompromised condition. So what are the signs and symptoms? You can think of this is the inflammation of the esophagus. So esophagus is around here. So that is if there is esophagitis, so that is the infection. So inflammation, the acute infection, acute onset of the dysphagia. I think that you know now what is the meaning of dysphagia. Dysphagia is difficulty in swallowing, food, water, because our esophagus is inflamed. So there is dysphagia. Whatever you eat, whatever the patient eat, there is a difficulty in swallowing. Food, swallowing of the food, water, whatever. This is known as dysphagia. Because of infectious origin, so dysphagia, difficulty in swallowing, is a manifestation of the esophagitis, as well as, I think you finished the cancer esophagus, right? So cancer, esophagus is also common. No, that dysphagia is a manifestation. So if it is infection that is associated with pain, no, this is a differentiating point. So but during history taking, you have to ask about it is a painful or not to differentiate. Is it an infection or to exclude that cancer? If it is the esophagus, no pain, no pain. So in case of esophagitis, that is associated pain, that is known as odynophagia. So dysphagia, odynophagia, that are the unique symptoms or unique signs and symptoms of the esophagitis. And also because of the infection, there is a pain. Pain is the retrosternal, behind the sternum, the retrosternal pain and heartburn and nausea, vomiting because of infection here. Nausea, vomiting associated with fever, because of infection. For esophagus, no fever. Also associated with abdominal pain, depend on the length of the esophagus. So if it is lower part of the esophagus, it can patient can complain with epigastric pain or abdominal pain. So weight loss is and not very common usually because they cannot eat. They cannot swallow, they cannot eat. Some association with like slight weight loss. But weight loss or cachexia is a major signs and symptoms of the esophagus. So these are the signs and symptoms. So I already told you esophagitis is a rare condition, but if it is associated with immunocompromised or immune deficiency like AIDS, cancer, leukemia, lymphoma, in this condition, you can see the case of esophagitis. So Candida albicans esophagitis, if it is Candida albicans, this Candida albicans causing esophagitis is an AIDS-defining condition. So that is a definition of AIDS. So patient, HIV positive patient may be HIV asymptomatic infection or later stage of the HIV infection, they progress to very severe immunodeficiency, AIDS. So if the patient present with esophagitis caused by Candida albicans, that patient is in the stage of AIDS, AIDS, very low, CD4 count. And also 8 to 28% of AIDS patients with dysphagia or odynophagia also have the positive culture for cytomegalovirus, meaning that the AIDS patient can present with esophagitis caused by Candida albicans, and these patients have also infection with cytomegalovirus. So what are the predisposing factors? You can think of immunocompromised condition. This is the predisposing factor, and use of antibiotic use. The broad spectrum antibiotics, because this antibiotic usage change the normal flora, and they have the opportunity of Candida to cause the esophagitis. So these are so what will you diagnose a case of esophagitis? Mainly clinical. So you have to ask, patient complain with painful swallowing, dysphagia, swallowing difficulty in swallowing. So these are the typical signs and symptoms of esophagitis. It must be painful because along the mucosa of the esophagus, there is inflammation. So you think of how much, how deep is the pain, throughout the esophagus. So in this case, you have to do the scopy. You have to look at the scopy. So to exclude the cancer, see esophagus, right? So esophago-gastroduodenoscopy. That is a scopy looking at the esophagus and also gastric. So you have to exclude the gastric ulcers as well, right? So duodenoscopy. During scopy, you have to look at the lining of the esophagus. If this A is the normal, with the gastroscopy. Not EGD, not esophagogastroduodenoscopy. If it is normal esophagus, you will see like this number 8, right? So this is a normal, nothing, no ulcers, no inflammation, no mucosa, healthy mucosa. So in case of Candida, Candida is the most important causative agent of infectious esophagitis. You will see like oral thrush, oral thrush, you will see the white plaque. So like this, the plaque, whitish color plaques, throughout the surface of the esophagus. This is Candida albicans esophagitis. So take the sample and examine, under the microscope, you will see the Candida. You can do the staining, So gram stain, gram-positive yeast. So how will you treat it? So Candida, you already know that, treat with antifungal, clotrimazole, and corticosteroids, because the whole mucosa of the esophagus is inflamed. You have to reduce the inflammation. So we need to use the corticosteroid in case of severe esophagitis. So avoid the using of immunosuppression. The immunosuppression, and also avoid the antibiotics. These are the predisposing condition. So prevention is don't do the predisposing condition, avoid the predisposing condition. Treatment is depend on the what type of infection. If it is fungus, antifungal. If it is CMV, maybe you can use some of the anti-herpetic drugs, antiviral drugs. So this is about infection of the esophagus, right? So next part of lecture is infection of the stomach and duodenum. I'm not very happy with teaching online, actually. I cannot see you. I cannot ask you. I'm looking at myself to look. Otherwise, I'm looking at the laptop. So now I'm looking at myself, my video. So I cannot ask you anymore. In face-to-face. Okay, I will. I will ask you some questions. Now is very okay. So regarding with the stomach infection, so you know that the stomach have inside the stomach that is gastric hydrochloric acid, right? So hydrochloric acid, with this hydrochloric acid, gastric acidity, most of the microorganisms go into the stomach. Most are killed. So what is the pH of the stomach? Inside the stomach, the pH. Although, because I can see you, the gastric acidity, the pH is
acidic 3.
Okay, round about
3 to 4, something like that.
Yeah, right. So maybe depend on the side of the stomach. Depend on the level of the stomach. That is the range is 2 to 4. Right? Okay, 3 to 4. So that is very acidic. The acidic condition. For example, those bacteria, they survive in alkaline condition like Vibrios. So most are killed by the stomach acid. So that's why if Vibrio can cause infection in human, that is cholera, right? So the dose of infection must be very, very high. 10 to the power 8, 10 to the power 10. The organism must be ingested. Otherwise, cannot cause the infection. Why? The stomach acidity killed all the Vibrio. Okay, so most of the bacteria cannot cause the infection of the stomach. The infection of the stomach is the infection of the gastric mucosa, that is gastritis, right? Okay. So The one bacteria that can associate with gastritis, gastric infection, stomach infection is Helicobacter pylori. You already know that, right? So you finish your one lecture. So Helicobacter pylori. So you will think of Helicobacter pylori can survive by the gastric acidity. Again,
Yes, doctor.
I cannot. I cannot control myself. I want to ask you, not somebody asks you. You're two-way teaching. So Helicobacter pylori can survive in the gastric acid and causing gastritis. Yes or no?
Yes, doctor.
Yes.
Yes.
So you mean that gastric acidity cannot kill the Helicobacter pylori?
Yes. Because Helicobacter pylori release ammonia. I think
Okay, that one is after survive, after surviving inside the stomach, some of the Helicobacter pylori multiply and produce something enzyme, so something like that. But my question is gastric acidity inside the stomach, acidity. Now the auto said pH is 3 or 4. This pH 3 or 4 can kill the Helicobacter pylori or not?
No.
Cannot.
Cannot.
Why?
Because it produce
They are acid resistant? Are they
No.
acid resistant?
No,
No.
they produce
No.
protease.
They are not acid resistant. So most of the organism, the Helicobacter pylori, when they reach to the stomach, they are killed as well like Vibrio, other organism. But a few can survive. A few they are survived. They are released. And then survive from the acidity. Cause the infection. Now, actually, gastric acidity kill the Helicobacter pylori. Helicobacter pylori are not acid resistant. Most are killed, but some organisms that are released by the gastric acidity killing effect, they go to where they go. They are hiding and taking the place away from the acidity, that is mucus. Inside the mucus there is no less acidity. pH is a neutral pH there, right? So okay, before going to pathogenesis, H pylori, what diseases caused by H pylori is gastritis, Enterogastritis actually also associated with, you can see H. pylori causes gastritis. And then from the gastritis, causing chronic infection, causing ulcers formation. So duodenal ulcer, gastric ulcer, all together with peptic ulcers, PUD. Peptic ulcer disease. And H. pylori, if I'm not mistaken, only one bacteria that is associated with cancer. Most of the microorganisms associated with cancer viruses. Virus is a oncogenic viruses, and also some parasites, like schistosomes and tetramatodes, these are associated with cancer. For bacteria, H. pylori, and this is the only one bacteria that is associated with C. stomach. So these are the infections caused by Helicobacter pylori. So what are the microbial characteristics? You need to revise again. So Helicobacter, not helicopter, Helicobacter. So they are gram-negative. The spiral rods, not like E. coli, not the straight. It's the surface. The shape is curved. spiral rod, actively motile. They have flagellus. This flagella is only at one pole, not only at one side of the body. So with this multiple flagella, they can motile. Now when they escape from the gastric acidity, because of this motility, motile flagella, they can go, they can find their place away from the gastric acidity. So the presence of multiple flagella in the Helicobacter pylori is the one virulent factors. Okay? And culture, Helicobacter pylori looks like, Campylobacter. Campylobacter, Helicobacter are the same, same group. So they are strict, a little bit, not like E. coli, not like normal. They are a little bit strict. So they need less oxygen. They can grow, less oxygen. And to get the enhanced effect of the growth, you need to add more carbon dioxide. So less oxygen, increase carbon dioxide, incubated at 37 degrees centigrade. So this is a normal, 37 degrees centigrade incubator. So you need to wait for 3 to 6 days, meaning that they are a little bit slow. You cannot get the culture positive within 24 hours. Maybe because of their strict condition, you have to wait to grow 3 days. So they are microaerophilic, less oxygen, increased carbon dioxide, wait for 3 to 6 days, and very strict. If you want to grow the culture, Helicobacter pylori on the culture plate, you have to use special medium, that is known as Scarro's medium. So you have to mix with antibiotics. So vancomycin, polymyxin B, trimethoprim, these antibiotics, antibacterial agents, they killed other organisms, and so H. pylori can grow. So meaning that you have to use special culture medium, mixed with antibiotics. And another characteristic of H. pylori is they are oxidase positive. The oxidase enzyme positive, catalase enzyme positive, and they are strong producer of urease. This presence of this urease is the invasive factor, virulent factor of H. pylori. And also based on this virulent factor, we can diagnose. We have to use special tests. Okay. So now it's a pathogenesis. So when the H. pylori go into the stomach, most are killed. But if they escape, a few escape from the killing effect of the gastric acidity because of the using of their active, multiple flagella, they find their way to escape from away from the gastric acidity. With this gastric acidity, they will be killed. So you see here, gram-negative calf organism, rod-shaped organism, and then they go to the mucus, because inside the mucus is very thick, but because of their motility, they can invade the mucus, thick mucus, and also they can produce the protease enzyme. So because of protease enzyme, a little bit lesser the thickness of the mucus, and they can invade easily. And then they stay inside the mucus. So inside the mucus, the pH is normal. Outside the mucus in the gastric lumen, that is acid. So H. pylori, why causing gastritis? They live inside the mucus, and then inside the mucus, they multiply and produce the urease enzyme. So this urease enzyme, hydrolyze the urea, imine and urea, and producing the ammonia and carbon dioxide. This ammonia is direct damage to the, you see ammonia, direct damage to the gastric epithelial cell. And also because of the presence of some strain of H. pylori can produce the cytotoxin. So that cytotoxin is GAT and VAC, vacuolating toxin. This cytotoxin causing a vacuolating, like vacuum formation in the epithelial cell. That is also causing the damage to the epithelial cell, leads to gastritis. So another factor causing gastritis is immune response, because of H. pylori initiate the activation of the cell, inflammatory cells, right? So neutrophil, so this neutrophil also inflammatory cell causes the inflammation. So finally, the H. pylori causes gastritis, right? So this is the pathogenesis. Now, if it is long-term gastritis, it can lead to gastric ulcers and upper duodenal ulcers. All right. So this is a pathogenesis. So you must know, H. pylori topic is very important. So MCQ, MEQ, whatever it is, in the final professional one, OSPE or something like that. You must know. Okay, so I already mentioned. Sorry.
We have like 7 minutes left.
I cannot hear very well.
10 minutes left.
Or 5 minutes left. Okay, because you can read lah. If I finish, I will stop.
Now we can do another.
You read it. This is like revision, but I focus what is the important one. So pathogenesis and pathology, I already mentioned it. And another one is diagnosis is also important. So how will you diagnose a case of H. pylori infection? Now, if the patient is gastritis, pain, ulcer, you have to exclude the H. pylori, So what specimen you want to take? You need to take, So it depends, If you exclude the cancer, say stomach, you have to do the gastroscopy, right? So if you do the gastroscopy, you can take the biopsy, gastroscopy and biopsy tissue. So this one is one specimen. Another one is, if you can determine the antibodies, you can take the sample of the blood. So you can take that rapid test like, you can do that rapid test like antigen detection. In this case, stool sample. So these are the specimen. Then how will you proceed? If you have biopsy material, so you have to do make a staining, silver staining or gemstone staining. And then if there is H. pylori, you will see the organism, the cuff-shaped organism in the mucosa. This is one microscopic examination. And also culture. Culture is because of very, they are strict, not like a normal one. The strict reduce oxygen, increase carbon dioxide. So usually not performed. But if the patient is treating with H. pylori drugs, antibiotics, not successful. So if you want to know susceptibility testing, you have to do the culture. So antibodies is not because antibodies are present most of the people. Now you also have already exposed to the H. pylori. H. pylori already exposed with us. So presence of antibodies have no role for the diagnosis. So what is that? Presentive diagnosis of the H. pylori is detection of the urease enzyme by the rapid test. Rapid testing. This is not the invasive test. The invasive test is gastroscopy. This is invasive. So rapid test is what you can do is urea breath test in the patient. The patient have to take the radioactively labeled urea, have to ingest it. So if the patient have in the stomach have H. pylori, this H. pylori hydrolyze the urea. This urea is radioactive label. So if there is H. pylori, So this urea is hydrolyzed, ammonia and carbon dioxide. So this carbon dioxide, hydrolyzed by the urease enzyme of the H. pylori, have radioactively labeled carbon dioxide. So if we can detect radioactively labeled carbon dioxide, you can say the patient have H. pylori infection. That is known as urea breath test. So another one is you can do rapid test after taking the biopsy specimen and then put it into the urea containing media. So if the H. pylori is present on the gastric biopsy specimen, this H. pylori hydrolyze the media and forming the ammonia, so there is the color changes. So now urea containing media, normal is no color. So after 1 to 2 hours inoculated with H. pylori biopsy material, gastric biopsy material, if there is color change, you can say this is the H. pylori presence in this patient. So these are rapid tests. One is in the laboratory, another one is on the patient. So on the patient is in vivo test. Now in the laboratory is in vitro test, right? So another one is you can do the rapid test for H. pylori antigen. So this is also good, take the sample of the stool and test for the H. pylori antigen rapid test, especially those who are taking antibiotics for the H. pylori eradication. It is cure or not cure, meaning the H. pylori is still present in the stomach or not. You can do the H. pylori antigen test. So before taking the test, stool antigen is positive. After taking the antibiotics, so stool antigen should become to negative. That is H. pylori antigen test. So antibody, I already told you, antibody is no role for the active infection. So we prefer to use the stool antigen test or rapid test, urea blood test or in vitro test. So treatment, I think treatment will be covered by pharmacology, right? So I just not complete the slides, not for the treatment portion. So treatment is not the monodrug therapy, So Dr. Bassett, I think will cover. That is the triple drug therapy, or maybe take 14 days, or 14 days, or maybe weeks, more than 1 month, or 4 to 6 weeks. So triple drug therapy or quadruple drug therapy depends on the physician. Okay, another one is epidemiology. So epidemiology, if you look at the epidemiology, most of the people, adult population, more than 50% of adult population have already exposed to the H. pylori infection. We are not knowing. If you take the sample of the blood, you are sample and then test for the antibody for H. pylori, you will get a positive. We are not sure when we have exposed to the H. pylori, because of what is the oral, oral route, by injection route. So in developing countries, more than 80% of adult population has already exposed to the H. pylori infection. Therefore, the presence of antibodies, detection of the antibodies, positive, is not role for the not the role for the infection. So if you take the antibody, if you have positive antibody test, you can say, or you have exposed to H. pylori, in some time before, something like that. And there is intrafamiliar clustering. Intrafamiliar clustering in it, because of the H. pylori infection is transmitted through the fecal oral route. So if it is very crowded, family and low income, low income people,